Welcome to this lecture on foot and toe evaluation. In this presentation, we are focusing less on memorizing test names and more on how to perform each assessment accurately and interpret what it tells you. The foot is small, but it has to absorb load, adapt to the ground, and create push-off. That means minor changes in the forefoot, arch, hallux, or nerve structures can affect gait and sport function. As we move through the deck, keep asking, where are the symptoms? What structure is being stressed? And does the finding suggest a routine mechanical issue or something that needs referral? These learning objectives give us the roadmap for the lecture. By the end, you should be able to identify important anatomy and palpation points, describe common foot and toe special tests, and explain what each test is trying to clarify. We will also separate flexible arch changes from more rigid structural concerns and connect exam findings to common presentations such as plantar fasciitis, Morton neuroma, turf toe, tarsal tunnel irritation, sesamoid pain, and midfoot injury. The goal is a focused, safe, and useful evaluation. Start by orienting to the anatomy. The calcaneus, talus, navicular, cuboid, cuneiforms, metatarsals, phalanges, and sesamoids all help distribute load. The plantar fascia supports the medial arch, especially through the windlass mechanism during toe extension and push-off. During the exam, first identify symptom location: plantar heel, medial arch, first MTP, web space, dorsal midfoot, or diffuse forefoot pain. Then observe arch height, toe alignment, hallux position, weight-bearing tolerance, and footwear wear pattern before palpating the key structures. Before special tests, assess motion and function. Look at static alignment, but also watch dynamic control. Check hallux flexion and extension, lesser toe motion, inversion, eversion, and pain during push-off. Strength testing may include hallux flexors and extensors, toe flexors and extensors, and intrinsic foot control when possible. Single leg balance, toe-off mechanics, and pain during gait often reveal more than isolated range of motion. The key is to connect what you measure to what the patient actually struggles to do. Subtalar neutral is used to estimate the neutral position of the subtalar joint and create a baseline for rear foot alignment. The patient may be prone or standing, depending on the method. The clinician palpates the talar head with the thumb and index finger while controlling the rear foot. Move the foot through inversion and eversion until the talar head feels equally prominent medially and laterally. Then observe or record calcaneal position relative to the lower leg. This is not a positive or negative test. It is a reference point for discussing pronation, supination, and orthotic considerations. The navicular drop test assesses dynamic pronation and medial arch collapse. Start with the patient seated and the subtalar joint placed in neutral. Mark the navicular tuberosity and measure its height from the floor. Then have the patient stand in relaxed bilateral stance and measure the navicular height again. The difference between seated and standing measurements is the navicular drop. A larger than expected drop, often described as greater than about 10 millimeters, may suggest excessive pronation or reduced arch control. Consistent foot placement and measurement technique are essential. The longitudinal arch angle estimates resting height of the medial longitudinal arch. The patient stands barefoot in a relaxed stance. Identify the medial malleolus, navicular tuberosity, and first metatarsal head. The angle is formed by lines from the medial malleolus to the navicular and from the navicular to the first metatarsal head. A decreased angle is associated with a lower arch, while an increased angle is associated with a higher arch. Use this as part of a broader picture with visual observation, navicular drop, symptoms, and function, rather than as a standalone diagnosis. Feiss line is a simple way to estimate navicular position relative to the medial longitudinal arch. Identify the medial malleolus, navicular tuberosity, and first metatarsal head. Imagine or mark a line from the medial malleolus to the first metatarsal head. Then note where the navicular sits compared with that line. A navicular that falls below the line suggests a lowered arch or pes planus pattern. This test is commonly used in lab settings because it is easy to visualize, but it should still be interpreted with symptoms, flexibility, and weight-bearing mechanics. The supple pes planus assessment helps determine whether a flat foot pattern is flexible or rigid. Observe the patient standing from behind and from the medial side. Note the medial arch height and rear foot position. Then ask the patient to rise onto the toes or observe the foot in a non-weight-bearing position. If the arch reforms, the flat foot is considered flexible or supple. If the arch remains collapsed, a more rigid structural pattern may be present. This distinction matters because flexible pronation is managed differently than a rigid deformity or painful progressive collapse. Compression and distraction testing can help assess MTP or IP joint irritation. Position the patient seated or supine with the foot relaxed. Stabilize the proximal segment with one hand and grasp the distal segment of the toe or joint being tested with the other. Apply gentle axial compression, then gentle distraction while noting pain, apprehension, restriction, or symptom reproduction. Pain with compression may suggest joint irritation, degeneration, or possible fracture. Pain with distraction may suggest capsular or ligament involvement. Focus the test on the symptomatic joint, not the entire forefoot. Varus and valgus stress of the first MTP assesses collateral ligament and capsular integrity of the hallux joint. Position the patient seated or supine with the hallux relaxed. Stabilize the first metatarsal with one hand and grasp the proximal phalanx with the other. Apply medial and lateral stress while comparing motion, pain, and end feel to the uninvolved side. Pain, laxity, or apprehension may suggest collateral ligament or capsular sprain. This is useful for traumatic hallux injuries, turf toe considerations, bunion-related irritability, and first MTP instability. The dorsiflexion-eversion test is used to provoke tibial nerve symptoms in possible tarsal tunnel irritation. Position the patient seated or supine with the foot relaxed. Stabilize the lower leg, then passively dorsiflex and evert the ankle while extending the toes. Hold the position briefly and ask whether symptoms are reproduced. A positive response is not just local stretch discomfort. It is reproduction of pain, tingling, burning, or paresthesia into the plantar foot. Interpret this test with symptom mapping, history, sensation, and Tinel sign rather than in isolation. Tinel sign at the tarsal tunnel screens tibial nerve irritability. Position the patient seated or supine and locate the tibial nerve posterior to the medial malleolus. Lightly tap over the tarsal tunnel and ask whether tingling or electric symptoms radiate into the plantar foot. A positive finding suggests nerve irritability, but it does not stand alone as a diagnosis. Combine it with the history, sensory findings, dorsiflexion-eversion testing, foot posture, and symptom behavior. Burning or tingling changes the differential compared with routine plantar fascia or tendon pain. Mulder sign assesses possible intermetatarsal neuroma, commonly Morton neuroma. Position the patient seated or supine with the forefoot relaxed. Compress the metatarsal heads from the medial and lateral sides while palpating the involved intermetatarsal space from the plantar or dorsal side. Ask whether the maneuver reproduces pain, numbness, tingling, or a pebble-like sensation. A palpable click with symptom reproduction may support neuroma involvement, especially in the third intermetatarsal space. Compare with footwear history and rule out metatarsal stress injury or plantar plate pain. The pencil test is used as a practical screen for painful loss of great toe extension, often discussed with hallux rigidus. The patient may be standing or seated, depending on the lab method. Place a pencil or narrow object beneath the hallux or first ray and observe whether the first MTP can comfortably accommodate extension. Pain, stiffness, or inability to tolerate the position may suggest limited or painful hallux extension. The key concept is not the pencil itself. It is whether the first MTP has enough extension for gait and push-off. Compare sides and consider turf toe, sesamoid pain, and degenerative restriction. To integrate the exam, match symptom patterns to likely conditions. Plantar fasciitis often presents with plantar heel pain, morning stiffness, and tenderness near the medial calcaneal tubercle. Tarsal tunnel irritation presents with medial ankle or plantar paresthesia and may respond to Tinel sign or dorsiflexion-eversion testing. Morton neuroma often causes burning or numbness in a web space with forefoot compression. Turf toe involves painful push-off and first MTP extension. Sesamoiditis creates plantar first ray pain. Dorsal midfoot pain with swelling or torsion should raise concern for Lisfranc injury and imaging referral.